Hey, clinical people. So today I'm going to do a brief walkthrough for you all of family therapy, and then your chapter also covers group therapy. So I'm going to go over that very briefly because we've talked about that in other chapters throughout the semester. So in family therapy, the system is seen as the problem. So the system here is the whole family. So it's not one person that's the problem. It's not one relationship. It's the whole family. What's going on with that one person who we call the identified patient, the person who has the eating disorder, the substance abuse problem, the disruptive behavior problem. What's going on with them is indicative of what's going on with problems with family as the whole. So that is the idea here. So the psychological symptoms that any member of the family is experiencing, but particularly those of the identified patients, are a byproduct of clients' dysfunctional families. So the systems approach looks at circular causality. That it's not like one thing causes the other, causes the other, causes the other. That's linear causality. It's like these things kind of go around in circles, they all kind of interact, right? It's recognizing that it's a little more complicated than that. So communications among family members, especially the patterns of communications, are a significant contributor. So we're going to talk about that as we go through. One of the things they emphasize that a lot of actually modern therapies emphasize is the idea of what is the function of this problem. So if your family is disruptive, how is that working for you? And this is something we often do in like cognitive behavioral therapies or ACT as well, is think about what good does this symptom do you? So like if someone's anxious, it might allow them to avoid something that's unpleasant. So that might be how it's functioning for them. And systems are looking for homeostasis, and individuals in particular are looking for homeostasis. So if there is a way that a particular individual feels comfortable within the family, they might sort of lash out or have sort of this feedback loop if there are any changes. So this is why sometimes when like one spouse, for example, loses a lot of weight, you'll see the other spouse sometimes sabotage them because they don't like that they're not both on the same page, or that this has changed the dynamic of their relationship. So how do you assess families? That's something we didn't talk about at the beginning of the semester. Obviously, it's much more complicated, right? So you're going to look at what is the presenting problem. You've got to understand what they think the causes are. They're not going to say it's the family, right? They're going to say, oh, it's this person's selfish or blah, 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 right? You have to appreciate the relationships within the family. How are they relating? Is it good? Is it bad? Like, how did it come about, essentially? And then you use genograms to check family configurations. And this is an example of a genogram. So here you can see where you would indicate where there are stronger relationships, and there are maybe poor relationships. You can see where there might be people who are jealous, or there's conflict. And the ages in the boxes are the numbers in the boxes are ages, and the circles indicate those who identify as female. The squares indicate those who identify as male, and as you'll see, this is actually the genogram for the symptoms. The conflict tactics scale is a scale that looks at how families handle conflicts, and it's really how we look for abuse and violence within families. Obviously, that's something you want to be aware of before you go into family therapy. If there is ongoing abuse, we are mandated as reporters to report that to Child Protective Services. So we need to figure that out right away. It's also obviously going to change the dynamic within the family therapy sessions. So it assesses how partners treat each other and how parents treat their children. It's objective, it's self-report, 40 questions, so it takes less than 15 minutes to complete. Then when you get to therapy, it's really critical for the therapist to relay to the family and really get them to buy into the fact that the idea that this is a systemic problem. Sometimes that's easier than others. So my professor, when I took a family therapy class in grad school, um, told us this story about this little boy that he saw who was disruptive, and in the very first session, the parents start fighting. The little boy looks at the therapist, the boy's like 8 or 9, and says to him, "Do you see why I have to act up? The only time they agree is when they're fighting with me, or they're both mad at me." And the therapist said, "You come sit by me. This is clearly not your problem," and addressed it that way. Um, Almost always, when you come to family therapy, there's an identified patient, one person within the family that's the problem. They have anorexia, they have substance abuse, they have behavioral issues, they have schizophrenia, something along those lines. So structural therapy was founded by Salvador Minuchin, and Minuchin really devised this therapy to deal with delinquency, so behavioral problems, and in particular anorexia nervosa. Um, as well. This is looking at how does the family affect those things? How can addressing relationships within the family help the patients overcome it? There's an influential and pragmatic approach here, um, and it's a lot of people respond really well to it. So, structural theory is concerned with what maintains a psychopathology, not what started it. Like Minuchin says, we can't change the past, but we can change what's going on right now. So, and these dysfunctional dynamics that they have within the family that are maintaining the psychopathology of the identified patient, but also the problems within the family itself. So Minuchin really talked about relationships between the family members, and in particular boundaries. So an organized family has clearly marked boundaries, and that's what we tend to think of as a normal or healthy family. I mean, these are weird words in psychology, right? Disengaged families are families that are not as interactive with each other as sort of your average family. They have very rigid boundaries between each other. And mesh families have diffuse boundaries. So in mesh families, there sometimes doesn't seem like there is a boundary. They're essentially all up in each other's business all the time. And that can be really problematic because the identified patient is typically looking for a way to control things in their lives and might develop a really self-destructive pathology as a result. So dysfunctional families respond to demands for change in pathological ways. So in terms of the therapeutic process, so your goal is to restructure families, to free members to grow and relate, again, in healthy ways, not these enmeshed, overbearing ways. Changing family structure involves changing rules for relating and changing boundaries. You want to educate them about what's going on. You want to try to help them reframe things. And the system creates more alternatives for healthy responding throughout the therapeutic process. The therapist wants to join with each member or subsystem of the family. Subsystems can be like sibling relationships, the parents' relationship with each other. The initial relationship with the therapist involves empathy, warmth, caring, a lot of the things you've seen from interpersonal therapy, humanistic therapy. And then once that's established, the therapist becomes an authoritative leader because someone has to be in the family, right? They're going to challenge, block, and disrupt homeostasis to try to help improve things. So it's active and fairly short term. And they are sessions that are pretty structured, you're going to address things head on. And then what happens when you're done is they have what's called booster sessions. You can have these in like cognitive family of therapies too. They're sort of natural and they come back and you're like, okay, the problem came up, we'll just address it. So as we talked about with the relationships, the boundaries between people are really important. And one of the things you'll hear talked about in family therapy is the differentiation of self. You want members of the family members to become their own person without sacrificing emotional closeness with other members of the family. So you sometimes have these emotionally fused members when you have that enmeshment, and it can be really problematic. Another thing we talk about a lot in family therapy and systems theory is triangulation. So this is where you've got two people in conflict, and then either one is going to bring in a third party and attempt to garner support. Typically you'll have like maybe parents are fighting and they try to like get the kid in on it. That's not healthy, right? And it's going to lead to unhealthy things for the kiddos because that's not a great position to put them in. Now, within family therapy, there's also solution-focused therapy, and this is where therapists just focus on solutions. They don't really dwell on problems. So there are different types of questions they ask in as a technique to achieve this goal. So exception questions. When was this not a problem for you? When was it not so bad? Because sometimes people think that things have just always been this way, right? Miracle question. If the problem disappeared, how would your life be different? This is something I often used to ask at the end of even my intake interviews. So like if I could wave a magic wand and fix you, what do you think would be different in your life? And then scaling questions. On a scale from 1 to 10, how bad has the problem been? As of this past week, is it better? What did you do to improve it? The narrative therapy is a way of creating meanings about self and events in particular ways. You have to be sort of cautious when using this with certain diagnoses because people, let's say, who have reality testing problems like schizophrenia, this could potentially be problematic for them. Multi-systemic family therapy, they use for adolescents with long-term behavioral or emotional problems, often involving legal offenses. And it uses elements from a lot of different types of therapy. And that's actually, I like that they mentioned parent training here because they don't really anywhere else. Parent training is one of the best empirically supported therapies for things. So you essentially just educate parents. How do you parent a child who has this specific problem, for example? So a lot of the cognitive or other empirically supported family-based therapies are this. We essentially are training the parents how to parent this child, and the focus is less on the kiddo. Now, there are some limitations here. Obviously, the DSM is only going to diagnose the identified patient, right? There's not a DSM diagnosis for, family conflict. So, again, as we've talked about throughout the semester, to get reimbursed for insurance, you've got to label someone with a diagnosis. But just doing that could reinforce the idea that this isn't a systems problem, it's this person that has the problem. And it can also lead to the same stigma that we've talked about throughout the semester for anyone who receives a diagnosis. It does tend to work pretty well, but it's hard to do that, right? Because the researcher has to take into account so many different factors. Efficacy studies comparing family therapy to, no treatment or wait list or some sort of placebo therapy shows that it works. It works really well for these problems, so schizophrenia, couples problems, so there we're going to be doing couple therapy, eating disorders, particularly anorexia nervosa in adolescents. This is actually currently the only empirically supported therapy for that. The CBTs haven't quite been validated for anorexia in the same way. Self-injury in adolescents, you can essentially do an adapted version of DBT. Delinquency in adolescents, conduct disorder, and other disruptive disorders. There's a lot of financial benefits as well because it can cut down on taxpayer cost or family cost. There have been 20 plus meta-analysis, shows that they're effective. The effect size is 0.65, depending on the metric you look at. That's either seen as a medium or strong effect size, so that's really good. There are positive effects, but they sort of go down over time. It's like any other skill, you kind of have to practice thinking this way, right, and acting this way. There's no difference in effectiveness between the different types of family therapy. And there's no significant differences between individual and family therapy. I like this quote: for now, it's a time. It's particularly effective in motivating alcoholics to join treatment. This is why the show Intervention is so popular, right? Because essentially, if you show the person like this is affecting us as well as you, then they're much more likely to be willing to seek some treatment. There's lower drug use after family treatment compared to non-family. Family treatment of schizophrenia reduces relapse, which is great. In schizophrenia, there are patterns that are very similar to enmeshment that can be problematic. And it outperforms no treatment and treatment as usual for youth who have conduct problems. All right, we're going to briefly talk about group therapy. We've talked about this a lot with DBT. You've seen videos of Yalom doing therapy before, so I'm just going to touch on this. So you can do this in a wide variety of therapies. So I have done myself a whole bunch of different types of group therapy. So I've done open groups that do just sort of a supportive environment. I've done very structured groups where you're actually administering therapy just like you would in an individual setting, only with the added advantage of them having other people to help them sort of navigate questions and come up with ideas and alternatives. So there are certainly lots of different ways to approach group therapy. The emphasis is on an interpersonal interaction. And the idea is that essentially being in a group helps you build interpersonal skills. And this partially comes from Yalom's idea and really an interpersonal or humanistic idea that all psychological problems are from flawed interpersonal relationships, and strengthening these relationship skills is partially the focus of therapy. So these are Yalom's therapeutic factors for group therapy. And you can see that a lot of these are kind of similar to other things we talked about for other therapies, right? But you sort of, some things that are really specific here, like interpersonal learning, group cohesiveness. Universality is a big one. So the idea is that everyone who has a psychological problem thinks they're the only one who has it. And then being in a group helps them realize like, oh, there are other people, and they immediately feel that affinity and they immediately feel that support. You can have homogenous groups where everyone has the same diagnosis. I've done this for people with like binge eating disorder or PTSD. You can also have other groups where people have different diagnoses, but they realize that they have similar reasons for these different problems. So they learn from in-group interpersonal experiences, and then that provides an opportunity for relationship practice. You can have open enrollment groups where members can enter or leave the group at any time. Sometimes we just call these support groups or process groups. I have led one of these for women with PTSD before, quite challenging. And then closed enrollment groups are where all members start and finish therapy together. These are often manualized treatments. For PTSD, we did one of these with cognitive processing at the VA. For eating disorders, I've done one of these using CBT for binge eating. So certainly these work pretty well. And then you have to really think about who is going to not be allowed in the group, right? Is there someone who their problem's too different, or maybe they're not gonna be able to understand things? You need to think about that. Big thing that they often recommend, especially if you're doing a larger group, is to have a co-therapist. One is just logistical, that you have a second set of ears and eyes for verbal and non-communication going on. But the big thing is you can, and we do this with couple therapy and family therapy if we can too, is that you can model a healthy collaborative relationship. And that can be really, really helpful. And one thing we warn about in group therapy is trying to limit extra group socializing, because what that can do is lead to more loyalty to the friendship than to the group. And this can also make others feel left out. In particular, if you're doing, let's say, like a DBT skills training group, and you know that these people already have relationship issues, you want to try to limit that within the group. Group therapy tends to be as effective as individual therapy and effective for a broad range of disorders. And it is then cohesiveness is a major contributor to successful outcomes. And it's also can be a really cost-effective approach to therapy, both for the client, but also for the therapist in terms of their time. All right, that's it for now. Hope that you all got a little more information that was helpful out of that.